Hello, everybody, and thanks for having me today with you. I would have loved to be there in person, of course, and I hope there will be another chance, another time. So I have no disclosure relevant to this presentation. I'm going to talk about retroperitoneal soft tissue sarcoma, recent advances in the management of these diseases. And as you should be well aware, retroperitoneal sarcoma represent only 10% of all soft tissue sarcoma. However, they are basically the most challenging disease for surgical oncologists. One of the first important things to consider when dealing with retroperitoneal sarcoma is that biopsy is very relevant. Biopsy is very important because tumors that appear to be sarcoma may not be sarcoma, and therefore the management can change completely. So when you see a solid mass in the retroperitoneum, you should always ask yourself what the diagnosis is like. And because the tumors like this that basically seems the same are completely different. On the left-hand side, you see non-Hodgkin lymphoma looking like the right-hand side one, which is a leiomyosarcoma. Again, here you see on the left-hand side a germ cell tumor, and on the right side, a diffuse liposarcoma, or an angiomyolipoma on the left-hand side, and the liposarcoma on the right-hand side. So it's important to consider biopsy, and biopsy is not dangerous. So the risk of seeding bleeding basically is virtually nil, and this has been now repeatedly reported in multi-institutional retrospective analysis, basically on a worldwide. The risk of seeding is in the 2% range, and the risk factor for seeding is the lack of use of a coaxial technique or a trans-abdominal approach, something that can happen also in experience center, like for example here, it happened to us for a patient who actually refused the posterior approach and in fact developed a seeding in the abdominal wall. So very important to use coaxial technique and the posterior approach, and then the risks will be basically none. Which is the accuracy of biopsy? The accuracy is pretty high. So in terms of histology type definitions, in excess of 90%. These are two basically experiences. One, the previous one on non-targeted biopsy. The weak part was the definition of the malignancy grade accuracy in the diffuse liposarcoma that in the past was very low because there was no use to target the more solid area, while in the recent years where the more solid areas are targeted with biopsies in order to understand which is the real grade of the patient that you are actually treating, even the malignancy grade accuracy has increased. It's not yet perfect, and we are still working on this, but it's definitely increased. And this is important, as you will see, because it will inform management. So primary retroperitoneal sarcoma, surgery. It's challenging here because these tumors tend to present late, they are large, the anatomical location is complex, and the tumors tend to are in close relationship with multiple vital structure, and this close relation to vital structure impacts on the ability to perform a wide resection. Why a wide resection? Because sarcoma need to be removed and blocked with adjacent structure, organs or whatever, in order to minimize the risk of recurrence. Historically, instead, the tumor was just the surgery was aimed at removing just the tumor, simple excision like this, which were followed by associated to a 10-year survival of 30%, and the risk of recurrence 5 years as high as 50-60%. And in fact, the local regional recurrences were the leading cause of death in these patients. However, in the extremity, where there has been, the largest, where it was developed, basically, the concept of surgical adequacy in sarcoma, extended surgical resection are also performed when tumors are located in difficult sites, like, for example, here, the popliteal fossa. And there is value in minimizing marginality. In other words, a planning in advance a positive close margin does not compromise local control as long as all others are negative. You see here, basically, the green and the red curves, negative margins, and planning in advance, positive margins. They have exactly the same outcome. So a tumor like this is not just shelled out because it will be marginal here and at the vessel side. It's taken out more widely in order to have to minimize marginality. So in this same approach can be translated in the retroperitoneum by removing some of the adjacent organ. And this, in other words, requires most of the time an ipsilateral nephrectomy and colectomy, the resection of the psoas muscle, diaphragmatic fold, left pancreatectomy and splenectomy in some 50% of left-sided tumor, pancreatic duodenectomy is 3% of right-sided tumor, and also vascular resection or orthopedic surgery when needed. So this surgery requires multiple surgical skills: GI surgery, hepatopancreatic surgery, vascular surgery, urologic surgery, gynecological surgery, orthopedic surgery. When all these skills are not available in a single surgeon, this surgeon who deals with sarcoma needs to be able to orchestrate a team of people that, in order to have all these skills together. So extended surgical resection was shown to be associated to a gain of 20%, an overall gain of 20%. And this was shown not only at single institution where different approaches were compared, but also comparing different approaches at different institutions. You see here on the left-hand side, the outcome of patients treated by extended resection, and on the right-hand side, those treated in another institution with a more limited procedure. Local recurrence in well-differentiated liposarcoma is at 18% against 40%, and the one of the liposarcoma is 40% against 60%. So a 20% gain, which is particularly true in liposarcoma. And nowadays, basically, the incidence of local recurrence in our hands has become 16%. 16%, so very low if you compare it with the 50-60% of the early days. Of course, in liposarcoma it's higher. It goes from 11% to 30%. In well-defended liposarcoma, but in leiomyosarcoma, for example, it's as low as 2%. Indeed, in the retroperitoneum, there is not only one disease, there are many different diseases. Retroperitoneal sarcoma is not just one tumor, it's a family of different diseases, at least 3 variants of liposarcoma, well-diff liposarcoma, G2-diff liposarcoma, G3-diff liposarcoma, leiomyosarcoma, solitary breast tumor, malignant peripheral sheath tumor, undifferentiated sarcoma, and so on and so forth. The local recurrence risk is basically high only in liposarcoma, while all other histology types predominantly have a metastatic potential, which vary across the different histology types, but they basically never recur locally if properly operated. So also the approach may change. So, for example, the need to remove systematically adjacent organs, as I explained, applies to liposarcoma, while in leiomyosarcoma, for example, in solitary fibrous tumor, one may have a more conservative approach without giving up to the concept of minimizing marginality. And this is so because they have a much better defined borders compared to liposarcoma, and this can be covered by retroperitoneal tissues, including fat, which in liposarcoma instead should always be considered the well-differentiated component of the disease. And they also have a lower risk of local recurrence if adequately resected. In malignant peripheral sheath tumor, of course, the approach is totally different because they are as femoral nerve, they lie under the psoas, so one can have an extraperitoneal approach, and you see here the patient lie on a side with an inguinal incision, you see inguinal incision, exposure of the tumor, and then resection of the specimen, which is psoas, tumor, and the femoral nerve without any other organ. Undifferentiated pulmonary sarcoma, similar approach, although when it approaches the vessel, one may need to perform an abdominal inguinal incision in order to control better the vascular tree and remove the tumor without problems. So all these need experience, and so data have been provided in the past, in the recent years, how the treatment of this patient at reference center is associated to a far better outcome. So it's very important to have to regionalize care of retroperitoneal sarcoma because this will impact the ability to cure your patients. How many patients a reference center has to treat to be considered a reference center? This is a question that is basically posed everywhere globally in these days, and no agreement has been found so far. However, at least some 13, 15 cases per year, or primary cases per year. In Europe, however, there is a proposal which is more ambitious to consider a reference center that is able to treat 20-25 primary retroperitoneal sarcoma cases per year. Now, once you are dealing with these tumors, it's also important to predict prognosis, and we have now tools that help predicting prognosis. One of these is circulator, and this circulator is helpful because it will actually help tailoring the treatment to the risk of the patient. Why is important? Because we may use also, besides surgery, neoadjuvant or neoadjuvant therapies, predominantly neoadjuvant therapies. The first one is, of course, radiotherapy. For many years, there were only retrospective evidence of the possible effect of preoperative radiotherapy on local control and survival. Here you see the two most recent examples, one published on Lancet Oncology on 99,000 cases using the National Cancer Database, and another one using the database of the Transatlantic Australasian Retroperitoneal Sarcoma Working Group in a more limited, in a similar time frame, some 9 years, focusing only on liposarcoma. You see that there was an association between the use of radiotherapy and local control. Finally, a couple of years ago, the first randomized study ever conducted in the disease on preoperative radiotherapy was published. And this study basically showed no difference in the abdominal recurrence-free survival between patients treated by preoperative and surgery compared to those treated by surgery alone. However, in the liposarcoma subgroup, there was evidence of a benefit. This was a subgroup analysis, so it's not in the overall population, but in a subgroup analysis, there was a clear benefit in favor of radiotherapy, while there was no benefit for leiomyosarcoma. It's important to state here that no randomized study have been ever conducted on intraoperative radiotherapy, so the intraoperative radiotherapy is of no proven benefit. In addition, postoperative radiotherapy should be banned because it's not able to be delivered. You can deliver it at adequate doses to control the disease. In parallel with TRAS, we also conducted an observational study on the patient that didn't make it for the study in the same institution, at least in the 10 institutions which contributed the largest number of patients to TRAS. So patients treated in the same time interval by the institution participated to TRAS, but off trial, were included in an observational studies, which basically gave us the idea of the real life data. And we show that we did a matched analysis in the Strexit population, 262 patients, showing basically that the same results of TRAS. And then we merged the matched population of Strexit with the TRAS population, showing in order to gain power in the subgroups, and we show that the benefit in local control of preoperative radiotherapy was seen only in G1-2 liposarcoma. G3 liposarcoma, which is the histologic type that also is associated to high risk of distal metastasis, and leiomyosarcoma, which predominantly fail at distant sites, didn't have any benefit from the administration of preoperative radiotherapy. What happens to other rarer histologic types in this site? So, for example, solitary fibrous tumor. Well, only very few patients affected by solitary fibrous tumor were included in STRAS, so STRAS doesn't tell us anything about these patients. I think one should always look at all the available evidence when treating sarcomas, and so in solitary fibrous tumor, there is evidence for solitary fibrous tumors at any size of any sensitivity to radiotherapy, and this evidence have been provided in a couple of publications in the recent years. So SFT, solitary fibrous tumor, should be treated by preoperative radiotherapy whenever needed because it's sensitive and it can help surgery. What about chemotherapy? So neoadjuvant chemotherapy instead is not a standard of care. It is somewhat standard of care in some high risks of tissue sarcoma, extremity, and trachea, but it's not, definitely not standard of care in liposarcoma and high-grade differentiated leiomyosarcoma and high-grade differentiated liposarcoma, although they have a high metastatic potential, and there is evidence that the leiomyosarcoma is sensitive to adenomyosin dicarbazine, and G3-native lipo is somewhat sensitive to anthracycline and phosphate. So, is preoperative chemotherapy something to be considered? Still an open question. While preoperative radiotherapy in liposarcoma is something that is basically always considered. And the study about this is ongoing, and so far has included 21 patients. It's been open 1 year ago. For the other rare histology types, one always, for example, like, I don't know, synovial sarcoma, Ewing sarcoma, desmoplastic small cell tumor, of course, one has to follow the same approach that is followed at other sites. So Ewing sarcoma will actually be treated by pediatric neoadjuvant chemotherapy protocols and so on. Finally, recurrent retroperitoneal sarcoma is what to do in recurrent retroperitoneal sarcoma. This is very challenging for the surgical oncologist. Here, I just want to say that, I mean, recurrence may mean different things in retroperitoneal sarcoma. It may be something that follows suboptimal primary resection. It may basically something that is not a real recurrence, is a persistent of an incomplete resection, or it may follow an optimal primary resection. So when a patient, that is a very common scenario when patients are treated in non-experienced center, undergo an incomplete resection, there is value in performing a completion resection. And this value has been shown in recent years, basically saying that patients who have undergone an incomplete resection may still be salvaged by an adequate procedure, tailored, I mean, targeted to the original extent of the tumor. While when local recurrence follow an optimal primary resection or a complete suboptimal primary resection, then surgery may be considered when the disease-free, if the histology is favorable, like, for example, well-differentiated liposarcoma, which is the best candidate, but also the disease-free interval is long, at least more than a year, and macroscopic complete resection is possible. If you follow these rules, basically, the further local recurrence risk after surgery will still be high, with a median time to a further recurrence in the 2-year range, and you see here, and complete resection possible, are not possible, are not met. One can consider preoperative therapy, and here you see a case of a deadlift lipo recurring in less than a year in a very difficult position. So if the tumor responds, and this is actually a tumor density response, so a tumor attenuation response, so a clear response in spite of the fact that the tumor didn't shrink, then you can consider surgery, even an extended procedure, like here, the patient undergo a pancreatic duodenectomy and blocked with a vena cava resection, which is fairly extended procedure, and the patient is in fact alive and without disease 2 years later. So it's a good result. And there is another tool to help you decide about this, and it's still also possible to be downloaded by using in an app. Is included in the Circulator app. Of note, a change in differentiation in recurrent liposarcoma is associated with worse outcome. So well-differentiated tumor which recur as they differentiated tend to have a more aggressive course. So it's important to consider when you and to factor in the treatment decision. So basically, response to chemotherapy is a good indicator to recommend further resection. So when the histology is unfavorable, short disease-free interval, macroscopic complete resection is doubtful, response to chemotherapy is a good indicator. And this is similar to strategies for lung metastasis from soft tissue sarcoma, where long disease-free interval or absence of progression on preoperative chemotherapy and macroscopic complete resection possible are the main indicators for metastasectomy. So all this evidence has been generated by the collaboration within the Transatlantic Australasian Radiotherapy Sarcoma Working Group. You are all invited to join our group, which was able to meet also in these very terrible days virtually. So we kept meeting virtually, and we did a lot of work. And so I hope to see you soon, and to see you also in the group to collaborate and participate in all what we have done to generate evidence in this very rare disease. So thank you very much. I stop here. Thank you very much for your attention, and I'm happy to take any question.
Thank you very much, Dr. Gronchi. It was indeed a great session, and I will hand over the mic to Dr. Arun Chandrasekharan, a very dear colleague from our own institute and now lead medical oncologist at Calicut. So Arun, stage is yours, and ask some crisp questions to Dr. Gronchi so we can move on.
Thank you, ma'am, and thank you for the invite. Always a pleasure joining you on a forum. Thank you, Dr. Alessandro, for this wonderful succinct. I think you've covered the A to Z, if not more, of retroperitoneal sarcomas here. We'll just quickly jump into 1-2 questions. One of the questions in clinical practice which we normally have is, do we use adjuvant chemotherapy in any subset of patients with retroperitoneal sarcoma, like how we do it in extremity sarcomas. Would you advise yes or no absolutely?
Well, in general, do you hear me okay?
Oh, yes, sir. Yeah.
Okay, thank you very much again for having me with you today. It's wonderful actually, and I'm happy well, I'm just sorry not to be there in person. That's the thing. In any case, so we don't routinely use post-op chemotherapy because when you give post-op chemotherapy, you basically don't assess response. And the same evidence that we have to recommend chemotherapy in high risk of tissue sarcoma in the extremity is not available for retroperitoneal sarcoma. So we would indeed consider some form of chemotherapy in leiomyosarcoma or high grade, so G3, the liposarcoma. Now, there has been a debate whether or not to grade the differentiated component of liposarcoma. We do grade it using the French system, and we see that there is value. So the lipo is not a high-grade tumor by definition. There are different nuances. So you have the intermediate grade one, which basically behave like well-differentiated liposarcoma, having a predominant local risk with a very limited risk of distant spread. While the high-grade one, so G3, according to the French system, the lipo, instead has a high metastatic risk, as high as the one of leiomyosarcoma. So in these two situations, G3 the lipo and leiomyosarcoma, we consider it, but we prefer to give it preoperatively for two reasons. Number one, because it is before a major surgical procedure, which most of the time would remove one kidney. And number two, because you can assess response, and so you can do something which sounds meaningful if the tumor shrinks or some form of tumor attenuation as shown on CT scan on a early detection, early assessment. While if there is no evidence of any effect, we would actually proceed then with surgery without, continuing chemotherapy that doesn't work.
Thank you. That makes sense. The second question was about patients who receive preoperative radiotherapy. Do you find it difficult later on when you go in for surgery, because we see that kind of question sometimes raised by our surgical oncologist? Would it compromise anything in any way?
No, not at all. Actually, not at all. It's a problem, and so radiotherapy becomes a problem if you operate the patients much later on as compared to what you usually do. So if you operated the patients 1 year later, then the administration of radiotherapy may be a problem. But since you don't do so, you basically do an operation between the, I would say, 6 to 8 weeks after the administration of radiotherapy. We don't see any major difference. Actually, in some situations, you also see some edema around the tumor, which helps separating out some of the structure that you may decide to leave. For example, around the duodenum, when they have the pancreas, it's more an help than a pain, actually.
And the final question is there any role for any debulking surgery in any patient where it's not possible to get an R0 resection and it's a slow-growing tumor, patient is having symptoms? Would debulking be advised in any case, in any specific situation, or?
It's one of the most challenging decisions, actually. So when to debulk a patient who has an inoperable disease is very challenging, because debulking for symptomatic reason may be something that doesn't make the patient more symptomatic than before you do the resection, right? And this may happen because you may get complications. It may happen because the things don't go well as you expected. So it's always an individualized decision to be taken on a case-by-case basis within the multidisciplinary tumor board, and considering all other possible solutions. Because debulking surgery doesn't cure patient, it doesn't help even a lot in progression-free survival. Indeed, there are situations where the bulk, the abdomen is full and the patient is really symptomatic and may not survive like this for long, where you may decide to go in, if possible, and reduce this mass just to allow the patient to breathe and so on. But these are very rare situations, and at the end of the day, most of these patients who die for local recurrence will die with a belly which is full of tumor, and no debulking
possible.
Okay. Thank you, Dr. Alessandro, for those answers too. And I think that's the question side. I hand over the dice back to Dr. Jyoti and thank once again for the opportunity. Thank you, sir.
So thank you, Dr. Gronchi. This was great session. Thank you, Arun, for taking these wonderful questions and in time. And we are really missing you see in person, Dr. Gronchi. And I'm sure that with the COVID getting a tail of it, that in the coming year we should be able to host you in person.
That would be
So,
nice. That would be great. Thank you.
right.